love to know a bit more about the audience today, so I thought I'd kick us off with a poll question, and I'd love to hear what your primary role is in the VA. And Rob, if you want to start the poll, that'd be great.
Let me try to do that. Things have been getting a little bit funky. The poll was giving us a hard time, but it's now started.
Great. The options we have for you today are student, clinician, student, trainee, or fellow, clinician, researcher, or administrator, manager, or policymaker.
And those answers are streaming in. So we'll give people enough time to make their choices. Let's see. A little more than half of our attendees have made their choices, so we'll give people a few more moments. Not everybody always answers the poll, so we won't leave it open too much longer. It looks like things have leveled off, so I'm going to go ahead and ask Maria to close the poll. I don't have access to it. Thank you, Maria. And the answers that we have are nobody chose student, trainee, or fellow. 39% are clinicians, 37% are researchers, and 3% are administrators. And there was a number of people that didn't answer. So we'll go ahead and close that poll and move on. And back to you, Anita.
Great, thanks, Rob. That's actually helpful to know. Okay, so before we get started, I thought I'd share a little bit about myself, why I'm interested in pandemic and disrupted care-related research, and my goals for this talk. So half the time, I'm a health services researcher at the Center for Innovation to Implementation, which is Palo Alto's COIN. The other half of my time, I practice emergency medicine at Palo Alto VA and San Francisco General Hospital. And it was almost exactly a year ago where I flew to New York to work at Elmhurst Hospital, which is where I trained, and unfortunately was also the epicenter of the COVID pandemic. And so for many reasons, the impact of the pandemic on patients and frontline staff are very personal for me. I also think it's really important for people that were and are on the front lines of this pandemic to have a say in shaping the research agenda and contribute to asking some of the questions. And that's partly why I wrote my first research proposal related to non-COVID outcomes in a very depressing hotel room in New York between COVID shifts. That said, my team and I were very fortunate to now receive a few rounds of funding to study the impact of the pandemic on healthcare utilization and veteran outcomes. And so today I'm here to share our early ideas and results in the areas that you see listed here. Our portfolio of work is very much a work in progress, which I was told was perfectly okay for the purposes of this talk. So in addition to sharing what we're doing in the space, I hope we can have more of a conversation, whether that's in the chat or the Q&A at the end or via email after this talk. I invite feedback, ideas for next steps, ideas for collaboration. If you're working in the space and doing something similar, I'd love to hear about it. And before I start presenting some of the work that we've been doing, I have one more poll question. And since we're covering a variety of practice settings, I think it'd be great to hear what areas you all are interested in or working in. I realize this doesn't cover the universe of options, but a few to get started. So Rob, I'll turn it over to you.
Sure, that poll is open now. And we are getting a number of answers in rather quickly. So we'll leave it open for a few more moments. Things look like they're slowing down a little bit. We'll give people just a few more seconds. And it looks like things have leveled off, so I'm going to go ahead and close the poll. I'll share out the results, and then I'll read them off to you. What is your area of interest / expertise? 17% answered A, primary care. 16% answered B, mental health. 0 answered emergency care. 3% answered surgery. 14% answered E, specialty care. And F, 37% answered other. I'm going to go ahead and close the poll. and turn things back over to you.
Great, thanks, Rob. Wonder where all my ER people are at, but that's okay. I'm glad that we have a nice mix of folks represented, and we'll be touching on many of these areas. So I know the resolution of this figure isn't great, but I think it's a nice framework to think about non-COVID outcomes. Actually, I think its origins were on Twitter by a VA clinician, and I've subsequently seen it reproduced in some articles, but essentially it describes the many pathways by which the virus kind of impacts health. So of course, first in the kind of steep, narrow purple curve, that is the immediate morbidity and mortality that results from direct infection with the virus. However, in addition to patients, there's a second phase illustrated here with a green line of morbidity, particularly in the short term, that is created by patients with non-COVID conditions who may have needed acute care but either deferred it or did not receive it. You all may have seen some reports early in the pandemic that rates of patients with heart attacks, strokes, appendicitis were down. Other factors like prolonged ambulance wait times, stay-at-home orders, and patient fears about acquiring COVID in the hospital also contributed to the morbidity in this phase. Then there's a third phase of health needs depicted here by the kind of navy-colored curve that will arise from longer-term impacts of interrupted care among patients with chronic conditions. So, you have initially stable patients who experience interruptions in care, and they may deteriorate over time. And our team is particularly interested in examining the effects of disruptions in primary care and elective procedures. And then you have the largest and longest fourth phase of healthcare needs depicted by the red line that encompasses the psychosocial and mental health burden associated with the pandemic, which may not peak until sometimes afterwards and will persist likely for months to years after the pandemic itself. Behaviors that are used as coping mechanisms during this time of increased stress may have long-term impacts on health and care utilization. People in recovery programs for substance abuse may experience relapse, or programs and meetings that took place before COVID-19 may not be available due to social distancing. Stay-at-home orders can contribute to feelings of isolation. And so I think this figure does a nice job of sort of capturing all the different impacts the pandemic has and will have, aside from just the immediate morbidity and mortality due to the virus itself. So our first area of study addresses some of the phase 2 concerns, and we were interested in studying how patient healthcare seeking behaviors and access to acute care shifted during the pandemic, and to determine if those changes led to negative health outcomes like excess deaths. We found that nationally, VA ED utilization dropped by 48% early in the pandemic. You can see this here in the teal line, which represents 2020. And so you see this sharp decrease following the onset of the pandemic, which is represented by the dashed line, especially compared to ED utilization in previous years, back in 2018, 2019. And I just updated this figure a couple of days ago to add 2021 data. And we see here is that while rates have increased somewhat, ED use remains significantly down compared to prior years. And as an ER doc, this kind of concerns me. I'm like, who are these missing patients? Are they deferring, delaying care? Are they sick and dying at home? Or, since we've made such a dramatic shift to virtual care in VA, are they getting their needs addressed somewhere else? And maybe it's true that our rates before the pandemic were too high, and we're seeing some low value care shifted elsewhere. And these are some of the underlying mechanisms that I think would be great to study in the future. And I should add that the decrease that we saw in the pandemic, at least early on, was mirrored in non-VA settings. Given the concerns about what impact the pandemic is having on mental health, we're also interested in looking at shifts in VA visits related to mental health conditions. As you can see, mental health visits also dropped early in the pandemic, however, to a lesser degree. We looked at this a while back, and we still need to update this with more current data to see how trends look over time. And I think we like to look at it broken down by various subgroups like PTSD, substance use, overdose, etc. We also did a breakout by ED disposition. So when a patient comes into the ED, they can either be admitted to the hospital or they're treated and then discharged back home or to where they came from. And you can see the ED discharges, which are depicted by the red line, decreased more sharply than the ED admissions, suggesting to us that patients were presenting more acutely to the ED. So next we decided to take a look at changes in ED acuity. And for those of you who may not be familiar with ED care, when a patient arrives to the ED, either as a walk-in or via ambulance, they're checked in and then they're evaluated by a triage nurse. And so in addition to asking patients, questions about what brings them in today and taking their vitals, triage nurses will use a triage tool called the Emergency Severity Index, or ESI. And the ESI is a 5-level ED triage algorithm that provides clinically relevant stratification of patients into 5 groups, from 1 being the most urgent to 5 being the least urgent on the basis of acuity and resource needs. And so here you see like a simplified version of that algorithm. So, the nurse-based assessment, like, is this patient actively dying? And so, you're thinking about your patient that's in cardiac arrest or is hemorrhaging out from a gunshot wound. Like, those are your level 1 patients. If not, then you ask yourself, is this someone that really can't wait? And if that's true, then that's a level 2 patient, and that might be somebody that's in like pretty significant respiratory distress. If that's not the case, then the nurse makes their best attempt to think about how many resources they think this patient may need. So someone that might need an IV, some blood work, an X-ray, that's many resources. And then they'll consider the vital signs. If the vitals are stable, that patient's a level 3. If that patient needs many resources but has unstable vitals, they might be up triage to a 2. If the patient maybe just needs an X-ray or some blood work, then maybe it's just 1 resource, and that could be a level 4 patient. You might think about like ankle sprain. And finally, if there's someone that they think that will need no resources, like maybe just a rash that needs to be looked at or needs some ibuprofen, these are kind of like our fast track patients. Those would be triaged as a level 5. And so because we have the ESI acuity level for all VA ED visits, we're able to examine trends in visit acuity over time. The VA sees very few level 1 patients. That's true pre-pandemic. And again, those are like your cardiac arrest patients. So those don't really change over time. You see here the panels 2018, 2019, 2020, and 21, which we were able to update recently. The biggest shifts in care following the pandemic, which is the dashed line, was in a drop in our level 4 and our level 5 patients, so the low acuity patients, and we see a bump in our level 2 and 3 patients. Think chest pain, shortness of breath, abdominal pain. Here we're looking at the same data, but in a slightly different way. We're looking at just high acuity visits, which we classify as an ESI level 1, 2, or 3. And we're looking at the proportion of ED visits that were high acuity. And we see a surge in these cases since the pandemic that persists today. So meaning the teal line is 2020 and the purple line is 2021. Please ignore that kind of wonky tail at the end. I wasn't able to clean that up for this presentation. But essentially, of the visits that we're seeing in the ED, the majority of them are higher acuity. So as I mentioned in the beginning, early in the pandemic, we started to see a few articles like the CDC report that came out that said there was a trend towards decreasing ED visits for acute conditions. The CDC reported 10 to 23% reductions in visits for heart attack, stroke, hyperglycemia. Many of these studies were limited to a few conditions or were single site studies. And I know anecdotally, my colleagues and I would sit in very quiet EDs wondering where all the patients with appendicitis or gallbladder issues were. And so in order to look at this a little bit more systematically, we decided to use a framework called emergency care sensitive conditions. So in a previously funded study, what my team and I did is we actually convened an expert panel to derive a set of conditions where we believed high quality, timely emergency care can impact morbidity and mortality. And the expert panel ultimately identified 41 conditions as emergency care sensitive conditions. And you see many of the ones that you'd expect to see: sepsis, stroke, heart failure, trauma, aortic dissection, ectopic pregnancy. And so we use these set of conditions to take a deeper dive into what was happening in the ED. So we see here, starting actually on the bottom left is data that you've seen before. So this is showing just the count of all ED visits, the blue line being 2020, and you see that ED visits went down, that you see. Now on the top, right above that, you see that of the patients that did come in, they were more likely to have an emergency care sensitive condition. So you see that spike in the blue line of ECSCs. Here, we're looking at the incident at the top. We're seeing the incident rate ratios of a few common emergency care sensitive conditions like COPD, heart failure, pneumonia in 2020 as compared to previous years. And on the bottom, we're seeing a change in the proportion. And what this tells us is that of all those excess emergency care sensitive conditions we were seeing, a lot of that was driven by an increase in pneumonia cases in the purple bar. Of course, our hypothesis is that this increase is likely underdiagnosed COVID and perhaps a reflection of under-testing that was occurring early in the pandemic. And I think it would be interesting for us to see how this varied across geographic regions and how this also varies by each of the individual emergency care sensitive conditions. So next, we wanted to look beyond utilization trends and look at outcomes. And here we're looking at all VA ED patients, and we're examining their 30-day mortality post-ED visit. And what we see is that there is an increase in 30-day mortality following an ED visit, especially in the first half of 2020 compared to prior years. If we drill down by emergency care sensitive conditions, we see an increase in mortality in the pneumonia group, and also surprisingly in the non-ECSC group, which is that kind of reddish, the blue dot. And at the top you see the IARs, and in the bottom you see the percent change in mortality. Our initial hypothesis was that maybe some of these non-ECSC visits, or the ones in blue, were visits that maybe were related to conditions like fever, upper respiratory illness, that were maybe actually just undiagnosed COVID. So to test that, what we did next is we decided to again look at post-ED visit mortality, but if we start on the left, here again are all ED patients. You see that increase in mortality. But then what we did is we sequentially removed certain patients. So first we removed all known COVID-19 cases using the COVID shared data resource, and we see that the mortality bump still persists. Next, recognizing that some of these cases early in the pandemic may have gone undiagnosed and treated, we then removed any ED visits that could have been COVID related, and to do that, we used a set of ICD-10 codes used by the CDC and other groups. So those would be things like fever, cough, upper respiratory infection, sore throat. And so even after taking out patients that came to the ED for those conditions, we still see a mortality increase. So here we do the same thing, but with the various emergency care sensitive condition groups. And if you remember before, there was that big increase in mortality among our pneumonia group. Now, if you look at the left, after removing both the COVID, and then you look on the right, after removing the COVID-like illness cases, that mortality increase in the purple pneumonia group, that essentially went away. We do still see a small significant increase in the all ECSC group when we look at the proportion of visits. So that's a small increase in that kind of reddish dot. And so we're going to spend a little bit of time figuring out if there are certain condition groups that might account for this increase. So to summarize, there was a large decrease in ED visits in VA early in the pandemic that has yet to rebound. Mental health related ED visits decreased to a lesser degree. The proportion of emergency care sensitive conditions increased, reflecting higher acuity ED visits. And I think there's still a lot more to explore in this area. And even just considering that the drop in ED volume has implications for how we staff the ED, how we organize and deliver care, and what this will mean if we continue to provide a lot of our care virtually, if that's where patients are going. And I think there's still a lot to learn about the underlying mechanisms of why it is that we're not seeing the same volume of patients in the ED. Also, we saw a significant increase in pneumonia-related ED visits in March and April. And like I mentioned, this may reflect issues with testing availability and capacity. And we also see that there's a significant increase in 30-day mortality following an ED visit, even for ED visits not related to COVID. So aside from the ED, we're also interested in seeing what impact uninterrupted care has had in other settings, specifically elective surgery and primary care. So to start, I will share with you our elective surgery project, which we just had published in the Annals of Surgery. So as many of you know, on March 15th of 2020, similar to many other healthcare systems, the VA issued a nationwide order to temporarily pause elective cases for an indefinite period of time. And this was done to reduce unnecessary exposure to the virus and to reallocate personnel, equipment, and resources for the anticipated COVID surge. There was a little bit of guidance from the American College of Surgeons for triaging cases and to help make decisions on which cases should proceed. But the term elective is really broad, ill-defined, and there is no consensus on what type of cases should proceed and under what circumstances. So as you might expect, suggestions and advice regarding how to triage cases varied across regions and disciplines, and the decisions were primarily left up to local clinicians and leaders instead of just issuing a blanket guidance. And so for many institutions, the VA included, these were case-by-case decisions determined which procedures would proceed both immediately after the pause and then later as surgical cases resumed. And so we were interested in learning if these delays or cancellations of elective procedures were associated with any negative patient outcomes. And so to do this, we identified patients that had procedures canceled during March 13th through 19th due to COVID and not due to patient preference or other reasons. And we compared them using exact and nearest neighbor matching to similar patients who had the same procedures completed in prior years. And then we examined their 30, 90-day ED use and mortality. So to examine the impact of cancellations due to the pandemic rather than changes in patient condition, we selected the cases that were canceled from March 13th through 19th. And as you can see here, cancellations spiked dramatically during the 7-day period, which sort of supported a claim that these cases were canceled due to the nationwide order. I realize this is kind of hard to make out, but just wanted to provide some basic characteristics of patients that had the elective procedures canceled due to COVID compared to matched patients in prior years. I'll just point out a few things. A slightly higher proportion of patients who had their procedures canceled due to COVID were Black. The mean age for both groups were about 64 years old, but the patients who had surgeries canceled were on average had fewer Alexhauser comorbidities. The surgical services with the most cancellations due to COVID were ophthalmology, general surgery, and orthopedic cases. The most frequently canceled elective procedures were lens and cataract procedures, accounting for 23% of cases, knee surgeries, 5%, colonoscopies, 5%, and therapeutic procedures on muscles and tendons, 4.5%. So apologies for this slide and next slide. The table that I included is from an earlier version, not what we ultimately published. So the numbers are off, but the overall message is the same. So apologies for that. The main take-home message is that when you compare patients who had their procedures canceled due to COVID and you compare them to patients who had their procedures completed in prior years, 30 and 90-day ED use was lower among patients who had their procedures canceled due to COVID. Even when we kind of stratify by different surgery types, like we use this complexity classification, the ED use was particularly lower in the intermediate operative complexity group. And what was reassuring was that cancellations were not associated with higher 30 and 90-day mortality, regardless of complexity type, which was good to see. We also then looked at the rescheduling of surgical cases that were canceled. And what you see here is that, this rescheduling did lag as VA continued to sort of adapt to the pandemic. Of the 3,326 canceled cases, and remember, these are not all the canceled cases. These are cases where we were able to do our matching. 2% were completed within 30 days, and 14.9% were completed within 90. Intermediate complexity procedures were slightly more likely to be rescheduled and completed than standard cases within 30 days. And that's, but it's pretty small. It was 3% versus 1.8%. Some takeaways here, patients with elective surgery procedures canceled due to COVID were less likely to have an ED visit in the 90 days following the expected case date. There could be a few reasons for this decrease in visits. First, patients commonly have ED visits after surgery. They come because they're in pain, or maybe they developed an infection or had a complication. So if surgeries are canceled, of course, there's going to be less of these kind of post-op visits. Also, we just spent most of this talk looking at the huge decrease in ED visits. So these results may just be reflecting that larger trend. That said, we were, again, reassured to see that patients with cancellations did not have any difference in 90-day mortality rates compared to similar patients with similar procedures in prior years. And what I think that really tells us is that this pause in elective surgical cases was not associated with short-term adverse outcomes. And it suggests that, our strategy of using this case-by-case determination and clinician judgment worked, and there was appropriate case management. Of course, further study will be essential to determine if delayed cases were associated with other long-term effects, like, maybe a canceled colonoscopy is not going to, result in 30 to 90 day, adverse outcomes. But if we start to see that these aren't rescheduled and we're missing, diagnoses of cancers, of course, that's a problem. And I should also point out that these results, of course, do not capture effects of other measures of health, including well-being, functional capacity, pain, and economic consequences. So you may not have died because your knee surgery was canceled, but it may have had other adverse impacts on your life. So we're also interested in doing something similar in the primary care space, and we're interested in looking if the reductions in VA inpatient in-person outpatient care had an impact on acute, had negative outcomes. And so our strategy for this is to look at patients that had an in-person primary care appointment scheduled and canceled during the early pandemic, and comparing them again to similar patients in prior years, and then looking at their outcomes, looking at ED visits, hospitalizations, mortality. I mean, we're still really early in this investigation, so unfortunately I don't have any results to share at this time, but hopefully maybe at a future date. One thing I can share is we started taking a kind of quick early look at what's happening with VA outpatient utilization. And what you see here, the vertical line is the start of the pandemic, and then going back, there's about a year's worth of data, and this is all VA outpatient care. And to the right is care since the pandemic, in its current, so it's as of a couple of weeks ago. And we broke out outpatient visits by to start just using the stop codes, the MCA HERC classifications, and you see what those groups are here at the bottom. And so it's just kind of interesting to see like where some of these shifts are happening. It's probably not surprising that ancillary testing, those encounters have dropped off since the pandemic. You see that there isn't a huge change in the outpatient like medicine, and what we don't have reflected here, which is true, I know others have been looking at this, is a large portion of those visits have been virtual, but the VA was able to, you can see, I mean, there was a slight drop early, but pretty quickly they were able to rebound and kind of still keep up the pace with the visits load that we had prior to the pandemic. Same with outpatient mental health, really not a significant change in the volume of visits pre and post pandemic. You do see, and sorry, that's the mental health being the red bars, I should point out. You do see that, you know, dental appointments took a hit for a while, which is not surprising. Surgery, which is the top brown bar. These are looking at kind of all outpatient surgery appointments. You know, those were down initially, but now have kind of been rebounding over time. And so that's sort of where we are in our investigation. I want to thank everyone on my teams, but you know, Liam Rose, DM Tran, Tracy Urick, Aaron Dalton, Winnie Wood, Todd Wagner, Steve Ash, and I want to thank HSR&D for funding our work so we can kind of answer some of these important questions. And I'm happy to stop there and take any questions or comments.
Thank you, Dr. Vashi. We do have a couple questions queued up, but before I read them to you, just let your attendees know, if you have a question after this presentation, please use the Q&A panel to submit them. I'll read them to Dr. Vashi right now. And I see a third one came in. Is the decrease in the ED visits after canceled surgery greater or lesser than the decrease in the overall ED use for all comers?
Can you repeat that question again one more time?
Sure. Is the decrease in the ED visits after canceled surgery greater or lesser than the decrease in the overall ED use for all comers?
Yeah, that's a great question. Thanks, Steve. We didn't calculate that exactly, but that's a great point, is that we could, right? I think you're getting to the point of, was this just a reflection of the overall trend in the change in ED visits? And yes, we could easily look at that, but we have not.
Thank you. Regarding short-term effects of canceled elective procedures, why were the time windows between the two comparison groups so different? And then in parentheses, they write 3/13 to 3/19, 2020 versus March/June of 2018/2019.
I just want to make sure I understand that question. If I recall correctly, we may have used a longer time period to find the appropriate matched patient and matched case, but the follow-up time period for the outcomes was the same.
Thank you. Are the visits face-to-face or include also telehealth?
I assume that's for the last figure, and those are all visits, not yet broken down into face-to-face versus virtual.
Well, those are the three that we had right now. It's possible that people were holding back, thinking that they'd give other people a chance to ask their questions. If there's anybody out there that has something that they weren't sure they were going to ask, please, we do have time. Go ahead and submit your questions to the Q&A panel, and I'll read them to Dr. Vashi. I think one just came in, if you just give me a second. Yeah, here it is. Great talk and exciting work. In your upcoming analysis and on outpatient care, do you plan to use quasi-experimental methods to address confounding due to those with canceled visits being sicker than those who kept their visits?
Yeah, and that's well, thank you for that question, Neil. That is something that we have been struggling with, because and that's why I haven't shared what we found so far, just because it has been difficult for us to find an appropriate comparison group. You know, patients that had their visits canceled this year are very different from patients who've had their visits canceled in previous years. And so we're still searching for a way to account for those differences.
Thank you. Are you going to look at VA, non-VA?
We are. We have just started incorporating community care data into some of our analyses. and looking to see, to what extent is care shifting from VA to community for certain types of visits. And so just getting started with that.
This one just came in. Did you say that mental health visits do not decline much? What about substance use related visits?
So in the ED work that we're doing, we did see that mental health related ED visits have declined. The figure that I presented at the start, that actually did not include substance use related ED visits because we classify those a little bit differently. But our next step is we're actually going to start using a lot of the same definitions that PERC and other mental health operations group use to see specifically by different types of ED visits for specific mental health related conditions, see how those have changed. They have decreased, but to a lesser extent than ED visits overall. And then if you're referring to the last figure where we're just sort of categorizing care in the VA and looking at the trend from the year prior to the pandemic and up till now, the overall proportion, if we're just eyeballing it now, which is what we're doing, has not changed much. But that's because it includes all outpatient mental health related visits, and it includes both virtual and in person. So, keep in mind that those include things like telephone calls, and of course there's going to be like a variation in the quality of those type of encounters and what those encounters were for. So we have not broken that down by substance use related visits at this point. I think though, let's see. Oh, there is substance. So there's a stop code here for outpatient substance abuse, and it's a sort of, I don't know what to call this color, pea green, I'll go with. But again, this figure was just from over the weekend, so eyeballing it here, that looks like there is a significant decrease in substance abuse related visits. So hopefully that might answer your question, John.
What can you say at this point about excess mortality in the VA due to the pandemic?
I think that's still a question that needs to be answered, and I think that there is I think HSR&D is planning for that to be a proposal that will answer that question. I think everyone has their thoughts that excess mortality in VA is going to be lower when compared to Medicare or looking at CDC data, but I don't have the data to prove that at this point.
Thank you. That's all we have at this time. Oh, I'm wrong. Another one just came in. Give me a second, please. Do you have any data on ED visits for non-ambulatory patients using wheelchairs?
I do not, but I'm glad that you asked that question because just discussing this issue with a colleague of mine who's really interested in disability-related research, and we are really curious, and hopefully we'll get funded to do this, to look at how the pandemic has particularly impacted patients with disabilities, whether it's vision, hearing, or mobility. One, in terms of just their access to emergency care and outpatient primary care, but two, with a switch to virtual care, it's obviously not going to be easy for everyone to make that switch. And I know that my colleague Carrie Gray is very interested in seeing how the switch to virtual care has impacted patients with disabilities. So I don't have that data, but hopefully in the next year she will.
Thank you. At the risk of being made a liar one more time, those are all the questions that we have at this time. Would you like to make closing comments?
No, just thank you for this opportunity to share our work. Like I said at the start, it's very much a work in progress. So, hopefully we'll have some more results to come in the future.
Well, thanks again, Dr. Vashi, for your work in the VA and for preparing and presenting today.